Here at the 33rd Annual San Antonio Breast Cancer Symposium, we're speaking with a very familiar face, a very familiar name, and a very respected doctor, George Sledge. Thanks for being with us. It's great to have you here.
A real delight.
Let's talk about some of your opinions, some of your thoughts on what transpired here at this symposium.
Well, this year I think we're seeing the fruition of many years of research in breast cancer. The last decade of breast cancer research has taught us that breast cancer isn't one disease, it's many diseases. When I speak to my oncology fellows, what I tell them is think of it as a boarding house where a group of criminals hang out. You know, some of them are petty thieves, some of them are killers. You need to apprehend them differently, you need to punish them differently. And we're seeing that now play out in the breast cancer field. We've got this population of estrogen receptor positive patients who benefit predominantly from hormonal therapy, but where we still have problems with resistance to hormonal therapy. We have HER2 targeted therapies where trastuzumab represents the basis in the adjuvant setting, but we're now exploring new combinations with new targeted therapies in the HER2 pathway. Then finally, we have this somewhat amorphous group of triple negative breast cancers that lack estrogen receptor, progesterone receptor, and HER2, where we're just beginning to look at new therapies that might be able to help us beat this disease. This year, I would say, showed some old stories coming to an end, but also showed the beginning of some pretty interesting new therapies that I think will take us forward.
Is there a specific area you saw shine here in San Antonio?
Well, in hormonal therapy, I think we saw something old and something new. The something old was one of the large phase 3 trials, and indeed one that I'm a co-author on, called MA27, that compared a non-steroidal with a steroidal aromatase inhibitor. And to make a long story short, while there's very minor differences in side effects between these agents, there's no difference in efficacy. So we have no particular reason to believe that one aromatase inhibitor is better than another. Now, at the same time, the remaining issue in ER-positive disease is resistance to hormonal therapy, and we saw some attempts to overcome resistance to hormonal therapy with a number of new agents. One of these was a IGF-1R monoclonal antibody, which in a randomized phase 2 trial was combined with hormonal therapy to see if you'd see increased benefit. And another was an mTOR inhibitor that was combined with tamoxifen in the setting of patients who had had prior aromatase inhibitor therapy. My view of those two stories is that first, the IGF-1 receptor antibody didn't appear to add anything to hormonal therapy. But in the setting of patients who probably have some resistance to aromatase inhibitor therapy, it looked like mTOR inhibition, at least in a randomized phase 2 trial, probably adds something to tamoxifen. And that's a very interesting prospect going forward. And I must say a little bit surprising to me because we had a prior randomized phase 3 trial in the hormonal therapy setting with mTOR inhibition where the trial had been fairly definitively negative. However, this was a different approach, looking specifically at patients who had already developed resistance to one hormonal therapy. And it may be that the invoking of pathways, such as the PI3 kinase mTOR pathway, as a result of resistance, actually sets you up for sensitivity to an mTOR inhibitor. And if so, and we have to await phase 3 trials to prove that this is the case, if so, this is a new direction in terms of preventing resistance to hormonal therapy. Real exciting prospect.
Let's take a look now at some of the key mTOR data presented here in San Antonio.
So I've presented the TAMRAD phase 2 study. That is a study in metastatic breast cancer patients that have been treated with aromatase inhibitor, either in the adjuvant and or the metastatic setting. And at one point they have been progressing despite of aromatase inhibitor. So those patients are considered as hormone resistant. And because you give them hormone therapy, but then they progress. And the theory goes that those patients that are hormone resistant have an activation of an accessory pathway, that is the PI3 kinase AKT mTOR pathway, that interact with the estrogen receptor and to have an activation of the cell despite the absence of estrogen.
What was the design of the trial?
The design was a phase 2 randomized trial with 53 patients per arm. The primary endpoint was to have an evaluation of the clinical benefit rates at 6 months. That is, a patient that were in complete remission or partial remissions or in stable disease at 6 months. And secondary endpoints included time to progression and survival and toxicity.
I know you were excited about the data. What were the results you shared?
Yeah, they're quite exciting because the primary endpoint, the clinical benefit rates, was 40% for the patient who were on tamoxifen, and it was 60% for the patient who received the tamoxifen plus everolimus combination. The secondary endpoint, time to progression, was increased from 4.5 months to 8.5 months with the addition of everolimus. That's an hazard ratio of 0.53. And the survival was increased too, because we had 25 patients who died with the tamoxifen alone at the time of analysis, and 9 patients who died with everolimus and tamoxifen, and that's another ratio of 0.3. Those results were significant, but this is a phase 2 randomized study, so you're not supposed to have a direct comparison between arms. What you can say is that obviously there's something that's happening, and giving everolimus on top of tamoxifen for those patients seems to bring something clearly.
Overall, what are the implications?
So the implications, the main implication, I think, is that it's confirmed that the PI3 kinase AKT-mTOR pathway for those patients seems to be very important when they have been on hormone therapy for one time with aromatase inhibitor, and then they grow despite hormone therapy. One of the theory is that there is an activation of this pathway, and you have an interaction between the hormone receptor and the tyrosine kinase pathway, and that allows the cell for future growth. So with our results, it seems to be that indeed that's what's happened for those patients. Moreover, we have made a subgroup analysis of patients who never responded to any hormone therapy and patients who did respond to hormone therapy and then at one point became resistant. And it seems that this inhibition of mTOR pathway is mostly important for the patient who did respond to hormone therapy and at one point became resistant. And that's very nice because that's exactly in line with preclinical data where it was shown for cancer cells that were grown for a long time in estrogen-depleted medium, that when they escape this hormone treatment, they have an activation of the mTOR pathway. So obviously that's opened the field for future research in this setting.
So where do you go now in your next steps of research?
There's two things there. First, to confirm our data, we have to go on phase 3 trial because, as I told you, this is small phase 2 trial, so you cannot conclude anything definitive about survival for those patients. And Novartis has already set up a phase 3 trial with exemestane and everolimus, that is a Ballve-Lantero study that is including at the moment and should be finished at the end of the year. So I hope we will have the results during 2011 or late 2011. And that's the first point. The second point is to try to develop more specific treatment for those patients. First, as I told you, it seems to be different for patients with initial hormone resistance, never respond, and patients who did respond and then became resistant. So maybe we should try some trial specific for those patients. And for the patients that did respond and then became resistant, the Ballve-Lantero study is trying to give mTOR inhibitor with exemestane, that is another aromatase inhibitor. But it may be worth trying with tamoxifen or Faslodex, that is another estrogen receptor inhibitor specific that may make more sense to use with the mTOR inhibitor.
Dr. Bachelot, thanks for spending some time with us and best wishes of success in your continued research.
Thanks a lot.
You got it. Here at this symposium, there were other pleasant surprises you had too, weren't there?
Yeah. Well, of course, one surprise, not surprise, but one bit of excitement to me is the rapid increase in our knowledge of breast cancer biology. We live in what I think is a revolutionary era in terms of breast cancer biology. And that's to say, as a result of the genomic studies that are going on, we are learning ever more about breast cancer, about best breast cancer biology, about what makes these cancers tick, about what allows them to become resistant to our therapies, and hopefully coming out of that, how we're going to be able to overcome it. I think something we should all be aware of is that we're probably about 3 years away from what laboratory scientists call the $1,000 genome. I spent an hour in the emergency room last year, and it cost me $1,000. 3 years from now, for $1,000, a breast cancer patient is going to be able to know absolutely everything about the genetic constitution of her cancer, and could also know absolutely everything about the genetic constitution of her normal cells. And that's going to be a powerful and liberating experience. It's going to be an avalanche of data that may bury us for some time, but it's also going to be a powerful and liberating experience going forward. It will mean that every patient's cancer is going to be informative in terms of tumor biology. And I think we can reasonably expect very rapid progress in terms of understanding breast cancer biology in the next few years.
What happens between now and that 3-year milestone you speak of?
Well, the other aspect of this, and an important aspect, and why the revolution is on hold, is that while we've had these astonishing advances in terms of the amount of data that's come in, we've not made up for that in terms of the pace of clinical research, and so that's an area where we have a lot of work to do. But even having said that, we have a number of trials that are already in the hopper that, if they prove positive, will be very exciting advances. We should hear sometime in the next few months whether or not PARP inhibition improves survival in a phase 3 setting for triple-negative breast cancers. We have trials ongoing in both the setting of HER2 positive and HER2 negative adjuvant therapy that are looking at anti-VEGF therapy as a way of preventing recurrences of breast cancer. We've just initiated trials looking at whether or not a metabolic intervention using a drug called metformin that our diabetes colleagues use regularly in patients with hyperinsulinemia, whether or not that might be beneficial in an adjuvant setting. So we've got a lot of exciting prospects that hopefully we'll hear about in the next few years. Certainly we'll hear about at least one in the next few months that should lead the way forward in terms of this disease.
How important is this excitement that you feel and that your colleagues feel about the data presented here in San Antonio?
Well, you can see it at the presentations. It's actually one of the great things when you're sitting next to your colleagues and you see a presentation and you look around at each other and you kind of know, this counts, this matters, this is going to change things. And you don't get that sense for every presentation, but you certainly have seen presentations at this meeting that fall into that criteria. I think I would love to be young again because I think the next 10, 15 years are going to be magical in breast cancer. I think our ability to perform research both in the laboratory and the clinic is going to speed up to an amazing degree in the next few years. And that should get us a whole lot closer to our goal of curing, I won't say curing cancer because there isn't cancer, of curing cancers, of curing the family of diseases that make up breast cancer, and indeed the larger family of diseases that make up human cancer. I truly believe that we are seeing the end game for breast cancer. It won't be easy, it won't be quick, it won't be cheap. But we're going to have enough knowledge in the next few years, I think, to eventually end this disease and make it a less frightening prospect for women with breast cancer.
Were there any other highlights you came away with?
Well, I'd say the area that certainly interested me the most this year was the area of HER2 biology. And here we have an increasing understanding of the epidermal growth factor receptor pathway to help us out in terms of treating the disease. We have had for many years trastuzumab that binds to the external membrane domain of HER2. We've had in recent years lapatinib, which is a receptor tyrosine kinase binder. We now have a number of other new agents that interfere with the HER2 pathway. And at this year's meeting, we had a very exciting session that looked at several of these in the setting of neoadjuvant or preoperative therapy, where the new was combined with the old or compared with the old to see how active it might be in terms of shrinking the primary tumor and inducing a pathologic complete response. And to summarize several studies that looked at a number of different agents, I think the lesson coming out of this is that blocking the HER2 pathway at more than one point will increase our ability to induce pathologic complete responses in the neoadjuvant setting. Now, if that's true in the preoperative setting, that gives us real hope that when the adjuvant trials, such as the ALTO trial, come out in the next few years, that we're going to see a significant increase in activity and a significant reduction in the likelihood of recurrence for patients with HER2-positive disease. I find that a very exciting prospect and was certainly reassuring that the preclinical biology that we've seen with these agents appears to be playing out in the clinic.
With everything that's been done and discussed here, what is the impact on patient outcomes as you go back to work in Indiana?
Well, I'm always happy if I just take one thing home that improves the quality of life or the length of life for my patients. Because we didn't have much in the way of phase 3 trials showing an improvement in overall survival, I'm not sure I can go back this year and say that we've had a major advance, say in the way that we said in 2005 when we had adjuvant Herceptin. But I think what I can tell my patients when I go back home is that the number of new drugs in HER2-positive disease suggests that we're going to have real advances, and I would predict positive phase 3 trials within the next 2 or 3 years in the adjuvant setting for some of these agents. And that in the metastatic setting, there's no question, but we're going to have new agents on the market in the next few years that allow us to increase targeting of the HER2 pathway. I'll be able to tell my patients that we are finally, it looks like, finally beginning to get a handle on the issue of resistance to hormonal therapy, a major issue. And I think I'm going to be able to tell my patients that in the setting of triple-negative breast cancer, as a result of the genomic studies that are coming down the pike, we're finally going to be able to get some new targets that don't involve giving patients fairly toxic chemotherapies. All of those represent real hope for women with breast cancer, and all of them, I think, are things that we can be happy of and indeed proud of in terms of having developed in recent years. Science cures cancer. Research cures cancer. Clinical trials cures cancer. And we're seeing the bringing together of an immense amount of laboratory data with strong clinical work, good clinical trial design in targeted populations, and that progressive segmentation of breast cancer populations, the specific targeting of those types of criminals, if you will, our ability now to fingerprint them, to apprehend them, to punish them, is becoming real. And we can only be happy with that.
Dr. Sledge, thanks for being with us and sharing your insights about what happened here in San Antonio.
It's been a real pleasure. I look forward to next year.
You got it. George Sledge, medical doctor, professor of medicine at Indiana University Simon Cancer Center.